Dear audience, thank you very much for your interest in this topic, Joint Hypermobility, Effect of a Resistance Training Program on Disability and Function. This talk is based on my PhD thesis, which I have defended in June 2023 at the Vrije Universiteit, Brussels. Welcome to my talk. Before I come to my thesis, I would like to explain why you can see here a special PhD candidate who is 55 years old with yet some gray hairs. As you all know, life is always a journey, and sometimes the way you have to take is longer. So I am to take you on my scientific, clinical and personal journey until today. This journey started as a PT with the basic education in Bern in the 1990s. Which then was not an academic education. But I was yet then interested in science and by chance got a job as an assistant in the gate lab of ETH Zurich, where I was engaged in sticking electrodes and markers to perform 3D gate analysis. However, the position was supported by a grant and thus ended in 2003. Luckily, I became a new position as a research assistant, just 20% at the Bern University Hospital, and there I'm still working, now it's 50%. During this time I learned very much on the job, but my wish was to do some kind of master study. In Switzerland, PT education shifted then to bachelor level, but no master was offered. So I did a joint MSc at the Academie Tim van der Laan. By the way, there I met Jean-Pierre Bayens the first time, who gave lectures. I finished this MSc in 2011 with a thesis looking at stair climbing in women with joint hypermobility. And finally, in 2013, I started as a PhD student here at Vrije Universiteit Brussels with the project I am presenting now. Not only life itself is a journey, but also science, with often long and variable ways. So here you see how I found the topic hypermobility as a research focus and how it developed. First thoughts started in 2005, and between 2006 and 2008, we did a pilot cross-sectional study with 31 women with GJH. Then a large cross-sectional study with nearly 200 women was planned and performed between 2008 and 2015. Yet in the end phase of this project, the idea of an RCT was developed and led to the planning of this thesis project, looking at strength training. During this journey, our research team not only gained more and more experience, but we also shifted the focus and aims of our projects. At the beginning, we centered mainly on biomechanical questions, like the contribution of active and passive structures, or how to measure specific tissue properties. For the larger study, additionally clinical questions raise up, like symptoms and disabilities. And finally, with the RCT, we focused on the clinical management, looking at effects and feasibility of a resistance training program. To finish this introduction, here the overview of the papers included in my thesis. From the second project, the paper dealing with stair climbing is included as Chapter 3. Chapter 4 is the main paper with the results of the RCT. Chapter 5 is an additional analysis of the baseline data, and finally Chapter 6 is a German paper with the focus on feasibility. Before I go shortly through the papers, I will give some background information and introduction, using the same headings as in the thesis. To start with the basics, what is the definition of joint hypermobility? The simple answer: a higher angular range of motion than usual in one or more joints. In the clinical setting, the generalized joint hypermobility, GJH, is usually tested by the Bateman score, with test movements of the fingers, elbow, knee, and bending forward. Originally, a person with 4 or more points was assigned to have GJH. Recently, age-dependent cutoffs were introduced, with 5 or more, for those between 20 and 50. So far, so good. But at this point is mainly the start of the discussion and reflections, and as it is often the case, the more one thinks about something and looks for answers, the more colors get the picture and the more questions raise. Thus, How much mobility is normal or even optimal? First, we can assume that joint mobility is normally distributed. There is a range of normal or optimal mobility in the middle, where movement is well controlled and pain-free, and where most of the people for most of the time move. Then there are persons with limited mobility, which we well know in physiotherapy. Patients with osteoarthritis, often an injury, or with limited mobility due to pain. We see these often, and there are many techniques in physiotherapy aiming to increase mobility. On the other hand, there are clearly persons with too much mobility, and they are termed to be hypermobile. On this side of the spectrum, little is known about the implications, and there, to date, is no therapy to reduce joint mobility. Many factors do influence the mobility of a single joint, and in general, thus the question what is normal cannot be answered easy. Maybe there are variant limits for different joints. There is for sure a dependence on age, because with aging, mobility generally decreases. Also, sex is an important factor, since women have clearly more often hypermobile joints. And the amount of joint mobility depends on training for specific sports, but also on daily life activities. The more a joint is moved over the whole range, the more it will keep the mobility, or can even gain more. So there is a wide range of factors influencing joint mobility, from genetic traits and anatomical properties to hormonal factors, as well as injuries or specific diseases. Based on these many factors, it is obvious that describing prevalence is challenging. In the literature, a wide range of numbers can be found, depending on the population, the definition of joint hypermobility, and especially the used cutoffs, for example, for the Baton score. A basic study is the 1000 Norms project in Australia, where at the cutoff of 4, 10% of the women between 20 and 39 years had GJH and 4% of the men. Other studies found higher values, with around a third of women in the USA, in Brazil, or in the Netherlands. When looking at these and other studies, the exact numbers might be not so important, but two findings seem clear. There are much more women hypermobile than men, and, maybe even more important, a significant number of persons with GJH have no problems and live happily, while a small amount of persons develop pain and associated symptoms. And this leads me to the next topic. Is joint hypermobility an advantage? Is it a problem or even a disease? This is a long-lasting discussion, and I think there will be no final and generally applicable answer. An illustration is the fiddler Niccolo Paganini, where it was speculated that he had pronounced hypermobility and thus was able to play melodies that others could not achieve. So it seems obvious that in some situations being hypermobile is advantageous, for sports like gymnastics or for ballet dancers. But some studies reported also higher risks for injuries or overuse problems in persons with GJH doing these activities. In general, the ability to stabilize the joints in various activities seems to be key. Important factors are the anatomical situation and passive structures, as well as the active stabilization, which mainly depends on muscles and respective neural control. And persons with GJH can have limitations in all of these aspects. Additionally, having GJH can also be associated with systemic complaints, like skin problems, or difficulties with vessels or the digestion. So to come back to my introduction, having hypermobile joints is a feature like blue eyes or red hair, but living with GJH is a journey through the whole life. It starts as a child, and you can entertain the others with clumsy movements. But yet then you can experience problems, for example, when handwriting in school. During adolescence, things may develop better or even worse. And there are many influencing factors, the hormonal changing, the growth, the activities performed, psychological stress when experiencing limitations in daily life. Then often follows a stable phase. You have found ways to move, you can dose your activities and cope with your GJH. And then, when getting pregnant and giving birth, new problems arise. The hormonal changes may lead again to symptoms, and the care for an infant can be debilitating. Later on, you hopefully find again the balance between the ability of your body and the demands of the daily life. The important thing is that you can adapt your activities so that they are suitable. Or other ways, you again overuse some structures and get injured. Finally, at older age, you possibly find more and better ways to cope with your GJH. And in some cases, being hypermobile might even be advantageous. And possibly through this whole journey, you may get various diagnostic labels, and that's my next topic. Here you see the overview of the diagnostic labels. The patent score was introduced in 1973, mainly for epidemiological studies. In 1988, the Berlin Nosology defined diagnostic criteria for connective tissue diseases, including the Ehlers-Danlos syndrome. In 1997, the Villefranche Nosology defined new criteria for the EDS, and in parallel, 1998, the Brighton criteria were introduced to diagnose the joint hypermobility syndrome. For several years they were used in parallel, and various letters and comments were claiming that both were the same entity. Finally, at a conference in New York, new criteria were developed and published in 2017, which is the actual nosology. As described for many years, the Brighton criteria were one set of symptoms to diagnose joint hypermobility syndrome. They are a mix of musculoskeletal symptoms like arthralgia, dislocations or soft tissue lesions, and systemic features like skin affection, habitus, or organ prolapse. The new classification 2017 then mainly described the 13 distinct types of EDS. 12 of these show specific genetic mutations, while the hypermobile EDS does not have such a marker. At the same time, it is by far the most often type, and is diagnosed mainly by clinical features: GJH, various systemic features, a positive family history, musculoskeletal features, and the exclusion of other explanations of the complaints, including the exclusion of the other EDS types. Additionally, as a new diagnosis, the hypermobility spectrum disorder was introduced, which is mainly defined by having JH and associated symptoms. Till today, no clear criteria for HSD were defined, so this is mainly the group of those who have symptoms and disabilities but do not fulfill the criteria for HEDS. However, yet now a working group is preparing clarifications of the criteria, which are expected for the next EDS conference 2025 in Toronto. Besides the various diagnostic labels, there is a wide range of symptoms and syndromes which can be associated with hypermobility. Often the exact relation remains questionable, and there are many different systems involved. The clearest association is with skin signs and connective tissue problems like organ prolapse. For cardiovascular, there can be problems with mitral valves or postural orthostatic syndrome. In neurology, small fiber neuropathy was described, and headache or migraines. Gastrointestinal symptoms can be very broad, from reflux and obstipation to pain and eating disorders. Chronic fatigue is often an issue, and in a discussion around long COVID, associations to GJH were postulated. Finally, even psychological issues are more often found in hypermobile persons, like depression or anxiety. Similar difficulties arise when exploring the direct consequences of hypermobility. As with the associated syndromes, it is often a chicken and egg problem, since it is not clear which part is the cause and which is the consequence. In the literature, various impairments were described, from lower strength levels and altered gait patterns to impaired proprioception and reduced balance. When thinking in the longer term, musculoskeletal injuries occur more often in hypermobile persons. The risk to develop chronic pain is doubled compared to others, and also the risk to develop osteoarthritis is higher. Other possible consequences are the conditioning and kinesiophobia, when a person loses trust in the body and regularly experiences pain or discomfort during activities. For therapy, there are two situations to differentiate. When acute problems occur, the management is primarily not very different from other patients and mainly symptom-based. However, an expanded patient information and education might be useful to reduce recurrence and support prevention. This goes then into the second part, the lifelong management, in terms of prevention and training. It is important to avoid overload and increase performance so that activities can be performed without discomfort. The support of self-management strategies is key, because many of these patients will have recurrent problems. The current recommendations for management are mainly based on expert opinions and experience, because there are few clinical trials, often with small groups and very heterogeneous interventions. Regarding the evidence for physiotherapy, it is summarized in a systematic review from 2021 with 8 RCTs and 3 cohort studies. 3 RCTs were pilot studies, the others I have listed here. The interventions range from inspiratory muscle training to stabilization or proprioceptive exercise and strength training. The 3 cohort studies researched various exercise programs. All these trials showed more or less improvements in various parameters, but no clear and concise results. Thus, no recommendations could be driven from these trials. And note that most of these studies were published after 2013. Thus, when preparing our study and planning the resistance training intervention, only 2 of these papers were yet available. So resistance training is a widely used concept in physiotherapy, using body weight, elastic bands, weights or machines, aiming to increase strength and function. Usually an adapted resistance level is applied to induce local muscle fatigue. Positive effects were described for various groups. Elderly persons improved strength and function, as well as patients with fibromyalgia, who additionally could reduce pain. Persons with low back pain showed pain reduction and improvements in psychological well-being, and people with knee osteoarthritis improved pain and function. Besides this therapeutic use, resistance training is also recommended for healthy persons and part of many athletic training programs. When bringing this together, these are the theoretical reasons to apply resistance training in women with GJH. Muscle weakness is an issue in those persons, and improvements in muscle strength might be important. Altered motor control and reduced proprioception are widely seen, and muscle strengthening has the potential to improve proprioception and joint stability. Specific training might increase muscle mass and stiffness, and thus provide support for joints and improve motor control. And an increase in strength has also the potential to increase body awareness and self-efficacy, leading to better performance. Based on these considerations, the intention of this project was to apply a resistance training program to women with GJH, with these 3 research questions. Is resistance training feasible and safe for women with GJH? Can these women increase strength and muscle mass by a 12-week resistance training program? And does the program have any influence on daily activities such as stair climbing and disability in daily life? Before I now go through the publications in chapter 3 to 6, I would like to do a short excursion. You have noted that I have illustrated this presentation and also the thesis with drawings. These were done by a colleague of mine, and I asked him to do also some drawings for my personal practice. He did a drawing like this, which I currently use for advertisements, and another one with a quite funny but also complex patient. But then, just a few weeks after he made this drawing, I had a referral for a complex hypermobile patient. She was a woman with many symptoms and very much pain. After amnesis, I asked her to lay on the bench for the examination. She said because of the pain she first has to relax a little bit. And she laid on the bench like this. Yes, that's her usual position, to relax and get rid of her pain. And by the way, she can also do the knots in the drawing, but this results then in even more pain. So patients with hypermobility, they can be quite surprising and very individual. But okay, back to the serious science. The first paper of my thesis, published in 2015, dealt with stair climbing, and it was a result of the large cross-sectional project we did. We included various assessments, ground reaction forces and EMG during gait and stair climbing, standing balance and passive tibial translation. Additionally, we asked the women about their pain and disability based on the Canadian Occupational Performance Measure. As a specialty, we asked our participants to record their symptoms during 6 months. The reason was that symptoms in joint hypermobility often fluctuate. The participants recorded monthly the frequency, intensity, and location of their symptoms. And based on these questionnaires, the hypermobile women were divided in subgroups as symptomatic or asymptomatic. Participants were women with Batten score 6 or more, between 18 and 40 years, without acute pain or trauma or surgery in the last 2 years, and not pregnant. Women for the control group were allowed to have 1 point in the Batten score. In the study, 128 women were hypermobile, whereof 56 were defined as symptomatic, and 25 women could not be classified due to missing questionnaires. For the mean curves of the ground reaction force, obviously no difference can be seen between these groups, neither for upstairs nor for downstairs. For the mean activity of the muscles, there were some differences, with mainly lower activation levels for hypermobile women, which was even more accentuated in those with symptoms. The conclusion of this analysis of stair climbing was that there were altered muscle activation patterns indicating a more cautious movement in women with hypermobility, possibly to avoid high forces, maybe because of reduced adroception or to avoid pain. However, the differences were small, and thus the main conclusion was that stair climbing as an activity was not demanding enough to really see the limits of these only lightly affected hypermobile women. Nevertheless, after this large study, our research group continued to the next project, which was a randomized controlled trial looking at the effects of resistance training in women with hypermobility. Included were 51 women divided in a training group doing 12 weeks of mainly self-guided resistance training and a control group not changing usual habits. The resistance training program was done on machines with the aim of muscle hypertrophy and focused on legs and trunk. Resistance was set at 80% of 1 repetition maximum, 12 repetitions were done and 3 sets. Training was 2 times per week, and instruction sessions were done in the first week, 3rd and 6th. Again, a wide range of assessments was included, ranging from biomechanical measurements to strength and muscle cross-sectional area, and questionnaires for general health, pain and disability. Here you see the data of the 51 involved women, whereby the in and exclusion criteria were the same as in the previous project. Note that about a third of participants fulfilled the Brighton criteria, and that we had quite many women with high Batten scores. To keep it short, here only the results for the muscle parameters. Depicted is the mean change between pre and post for the two groups. Of the three main parameters, only for muscle cross-sectional area a significant difference between the groups was seen. Additionally, also for the total area of the thigh and for the respective muscle mass. However, when calculating the percentages of the change, these values were very low, and clinical significance of changes of 2 or 3% is quite questionable, despite statistical significance. There are several possible reasons for this negative result. On one hand, the strength gain could have been not measurable by our assessments, because the training was dynamic and the assessment is isometric. On the other hand, and possibly more important, the training intensity might have been too low, maybe due to lack of motivation or fear of pain. Thus, maybe more intense coaching by the PT would help to avoid such low intensity. So to conclude, resistance training might be an option for women with hypermobility, but there need to be adaptations in the form. To become better insight in the muscle properties of these women, we performed an extended descriptive analysis of the baseline data. Basically, the participants and the assessments were the same. The focus was on the muscle properties, on one hand strengths, measured isometrically by a force transducer for knee flexors and extensors. On the other side, the cross-sectional area of the thigh and shank, measured by PQCT and calculated for various cross-sectional areas. To illustrate the PQCT measurement, you see here a cross-section of the thigh, with the bone in white, the muscle in light gray, and the fat tissue in dark gray. For this analysis, all 51 participants of the RCT were included. Based on amnestic checking of the Brighton criteria, 22 were classified as having GAHS. For the analysis, the whole sample and the two subgroups were analyzed and compared. First, some selected values for the tissue properties at the thigh. The main finding was that there are no differences between those with GJH and JHS in all parameters, indicated by the very high p-values. The maximum strength for the knee flexors was 22% lower in those with JHS, while the rate of force development showed no difference. To conclude this chapter, some points from the discussion. There was a tendency for lower strength in those with JHS, but there was no differences in the cross-sectional measurements. The correlations between the measurements were mainly moderate or not significant. And the study had limitations, mainly because we could not integrate a control group with normal mobility. And sample size was too small, since the power was calculated for the RCT, not for this subgroup analysis. For such a study, 130 to 150 women would be necessary to achieve 80% of statistical power in the analysis. So we come to chapter 6, which is a special one since this publication is in German and is in the thesis included also as an English translation. So why include a German paper? As you all know, a big issue in science is the dissemination of results and the application of the evidence in daily practice. These difficulties are yet well established in English-spoken countries. In those with other languages, like in Brussels or in Switzerland, it is even more accentuated. Most Swiss physiotherapists do not regularly read English journals. Furthermore, the main publication was in a more general journal at BMC and not in a specific physiotherapy journal. So a possible solution is to publish some parts of the results also in German papers that have a broader audience. Thus we planned the publication in Physioscience, and I obtained the consent from the faculty to include such a German paper in the PhD thesis. The study was a pre-post project subsequent to the RCT. The training group of the RCT was included, and additionally to the participants in the control group, the same training program was offered, and 19 women agreed to do so. For the analysis, all 46 women who performed the training were analyzed. And again, the two subgroups, GJH and JHS, were compared. The training program was the same as described and also the assessments. The focus was on discomfort and pain triggered by the training, and all participants filled in this questionnaire weekly. The analysis of this questionnaire was mainly descriptive. About 2/3 of the weeks were without problems during or after training, and in nearly 1/3 of weeks just low discomfort occurred. In about 6 to 8% of the training weeks, moderate or even significant pain occurred, with those with GJS having more of these episodes. The detailed analysis of the training weights confirmed the yet mentioned low weights during training, illustrated here for the leg press. In short, they started with low resistance, around 40% of body weight, increased only little and ended after 12 weeks still clearly below their own body weight. The most important discussion points from this paper are the 12-week training is feasible, there were few dropouts, a good adherence and only little discomfort experienced. Contrary, the implementation is questionable, since the women started with low weights and did not increase very much. Thus, training rates were often too low. And again, there was high variability in the included persons, and thus also in the individual training effects. So after these spotlights on the papers included in the thesis, I want to conclude with the general discussion and come back to the research questions. These are, in short, the answers. Is resistance training feasible? Yes. Resistance training is a possible option, and risk for pain and injuries seems not to be increased. Can women increase strength and muscle mass? Not necessarily, at least not with this self-guided 12-week training program. The women did not significantly increase strength and muscle mass. And does the training influence daily activities? Likely not. In the present study, no changes were seen for activities with low intensities like stair climbing and daily function. These short quotes clearly need some clarification and more discussion, also in comparison with other studies in the field. Regarding the effect of the resistance training, we found that the changes of strength were very variable. The participants mentioned fear of height weights and possible pain after exercise, as well as a general aversion against fitness training and exercise machines. Thus, our conclusion was that resistance training is an option, but more guidance and an individualized prescription seems necessary. When looking at a few other studies looking at the effects of resistance training, this conclusion can be supported. Similar strength gains were described for persons with JHS and GJH. A reduction of pain and increase in quality of life resulted after 4 weeks of exercise, while better shoulder function was seen after 16 weeks of a high-load strengthening program. And the recent pilot study with similar exercises and assessments as our own showed promising results. The main difference was that the resistance training was fully supervised, and hopefully the full trial of this will follow and give better insight in this topic. Another point to discuss are the developments in the field of hypermobility. Over the last 15 years, many things have changed, and yet the definition of inclusion criteria was challenging. This on the background of the discussions regarding diagnosis, and finally the new classification in 2017, together with ongoing debate on the validity of the Patent score as a tool to define GJH. Another issue was the lack of specific assessments for persons with hypermobility disorders, which has now changed in parts. One new tool is the Spider, aiming to record symptoms in various dimensions. Another one is the Bristol Impact on Hypermobility Questionnaire, which records pain, limitations and impairments related to hypermobility. Finally, the field in general has massively evolved, visible by the number of papers published. The relevant literature has grown substantially, with currently more than 100 publications every year. So I switched to the strengths and limitations. This was, to our knowledge, the first RCT implementing a resistance training program for hypermobile women. The trial had an adequate group size and was analyzed by intention to treat, which is a main strength, confirmed also by the Pedro score of 8 out of 10. We implemented a clear and structured training program and had a broad range of assessments included. Regarding the limitations, the main points were described. We had a very heterogeneous study group, and they were, at least in parts, subclinical, with only few complaints. The functional assessments were not enough demanding, and they used questionnaires not specific enough for our participants. So finally, to the general conclusions of my thesis. Individually tailored physiotherapy, including resistance training, is useful in the management of hypermobility disorders. Structured and concise tools to assess symptoms and disorders in various dimensions are needed for clinical and research use. And more concise assessments than the Baton score, including additional joints, might help for better diagnosis and classification. For further research, the suggestions are to identify and validate outcome measures, to identify proper types and modes of exercise, and to explore the relation between physical fitness and the response to training. For our own research projects, the next ideas are to perform single case studies to investigate management, then to translate the Bristol questionnaire into German, and to test and implement additional assessments like the upper limb hypermobility assessment tool and the lower limb assessment scale. And with this, we'll finish my talk and give a big thank to all the persons involved in the various projects who supported me and helped in the conduction of all this research. A very special thank goes to my supervisors, Jean-Pierre and Eric from Brussels, and Martin and Danielle from Bern, who always supported me and had the necessary patience and energy on this quite long journey. And I give a big thank for your interest, for your attention, and to close the presentation and start a discussion, I show at the end the motto of my thesis, say that we may get a glimpse of the vastness of our ignorance when we contemplate the vastness of the heavens. Thank you for listening, and if you have any questions, just write me and ask. Thank you very much.